welcome to today's podcast where we explore the forefront of critical care medicine. Today, we are honored to have Dr. Bharat Jagiasi with us. He's the Director of Critical Care at Kokilaben Hospital in Navi Mumbai. We all know him as the General Secretary of IACCM, and he's the Organizing Secretary of Criticare 2025, which is going to be held in Kochi. Dr. Jagiasi will be discussing with us the latest ARDS guidelines and innovations paving the way in intensive care. Stay tuned for an insightful conversation with one of the leading voices in this field. Welcome you, sir.
Thank you, Dr. Monalisa, and thank you for the kind introduction, and also Dr. Jaicob, hello to you as well. So it's nice to be on the board. I mean, I'm seeing all through this, the podcasts which have been happening throughout this year. You guys have extremely done well. And being a General Secretary on behalf of ICCM, I should thank you all for doing this for us. So yeah, I'm all ready for this. Tell me, please.
Thank you for joining us. So we'll start with the first question. Could you explain the evolution and significance of the global definition of ARDS and how it differs from the Berlin definition, and what is its utility in clinical practice?
It's a good question to have. So when it comes to the ARDS, if you all know, it all started maybe way back on 12th of August 1967, and this was the time when the first initial statement came in about something called as acute respiratory distress in adults, because initially the same thing was defined in infants. The infants were seen, so they found something of similarity in the adults as well, and the first paper was published on 12th of August 1967. And taking this date, if you all are aware of, we celebrated the first ever ARDS day in India, and I'm proud. I'm General Secretary, and we were the one who initiated by the IACCM. So it was also, I was amazed, up till now, no one amongst the global community has done this ever. So this is how the 12th August comes in. Now every 12th August we'll be celebrating the ARDS day. So this was the term coined. Then came something called as adult respiratory distress syndrome, which happened in somewhere around 1971. And then there was a 4-point lung score, which happened in 1988. And there was an American European consensus conferences where we all know it happened in 1994. And they came with certain statements. And of course, now what we all been following is a Berlin definition of the ARDS. So Berlin definition is being there since long, and we've been following it up. But the problem with the Berlin definition is it's been there since 2012. It covers 4 areas. We all know it. It covers the timing, that is within 1 week of known clinical insult or the new worsening symptoms within a less than 1 week time. We also look at the chest imaging, bilateral opacities, and the nodules in the X-ray or the CT scan. And also the origin of edema should be non-cardiogenic, and we look into the oxygenation level as a PF. Now the whole problem within this is, this came in 2012. So after that, we had the advances in the critical care. So we also started doing the sonography, and there was no understanding of it. How would the definition look when it comes to the sonography? And also we've been using quite a bit of NIVs and HFNCs. So there's a problem within the Berlin definition when it comes to the resource limited settings as well as the resource rich settings. So when the resource limited setting, of course, you need to have the access to the ABG to define about the mild, moderate, and patient needs to be ventilated. And in the resource rich settings, we all been using NIV and the HFNC. So because the definition is such that those patients cannot be labeled as ARDS. So we were losing quite a quantum of patients which are actually ARDS treated with the NIV and HFNC, and we couldn't label them as an ARDS. So this is why a group of, if I'm not wrong, 32 intensivists, critical care specialists, experts in ARDS representing different global societies sat down, and they then came up with a consensus statement which came up with the new definition of the global definition. So it was about the less than 1 week of the onset, it remains the same. So in the imaging, they also added the ultrasonography. So like B lines could be seen on the ultrasonography was also added apart from the bilateral consultation. And in the oxygenation area, if someone did not have an access to the ABG machine, they added the SpO2. So apart from the PF ratio, it was a SpO2 and F ratio. If it was less than 315, you could take it as an ARDS. And they also included the HFNC, the flow rate, if it's more than 30 liters per minute. Again, that patient also be included in the ARDS category. And Also, in the resource limited setting, they said if you feel if it's an ARDS, then the ventilation and HFNC is not required. So quite a bit of additions came down to it. If you allow me, I can share one slide, if I'm allowed to do that, where you can actually see how it varies and what all areas they have looked into. Am I allowed to share? Yeah. If you see this, this is what it looks like. Timing, as I told you, is less than 1 week. Then origin of edema should not be the fluid overload. It should be the non-cardiogenic, and they've added the B lines as well. So when it comes to the non-intubated patient, you can also include the NIV flow rate of less than 30 and CPAP of at least 5 centimeter. So these are the sets which was included. And of course, in the intubated ARDSs, if the ABG machine is not available, so instead of the PF ratio, we could also do the SPO2F ratio as well. And in the resource limited settings, as you all said, they said there's no need of PEEP or the flow rate. You can define those patients as an ARDS. So this is how it came down to this. So I'll just stop this. Yes. So here the advantages is when it's a global definition, we have the broader inclusivity. So we have the new definition which covers more of the patient population, even though they are on the non-invasive ventilation or the HFNC they're applied. So there's a practical implication. There's an application of the pulse oximetry as well. So it improves our overall research potential because the more patients are involved, and the recognition of ARDs also is there in the non-intubated patient, but it has its pitfalls as well. So potential of the overdiagnosis, as I told you in the resource limited settings, they said there's no need of PEEP or the flow rate. So sometimes we might overdiagnose these patients, and the patients which are hypoxic, actually not ARDS, they have the better survival rate as well. So the mortality rate is really low in those patients. So what will overall will happen is, we all know ARDS is a difficult condition to treat. The mortality is very high, but when you take those non-ARDS patients into the consideration, the mortality will really go down, and it might put the pressure on the treating physician who's treating the really true ARDS patient, and the benchmark is when it's really low. Also, the pulse oximetry, we know it could be the bias related to the perfusion, related to the dark skin tones and all. We are not very sure how it's going to play a role. And of course, in certain areas, very low pulse oximetry when the SpO2 less than 70 and all is not really very well studied. So of course, the various clinical trials are on and we are looking into this, but it has its own advantages as well as the disadvantages. I hope I have answered this question as per.
Yes, very nicely. Thank you so much for taking up that question and explaining us the difference between the Berlin and the new definition of ARDS.